And then we do see RA and juvenile RA affecting the forefoot of the foot, the forefoot, and then it progresses to the hind foot and then up to the ankle. So we do see, similar to you see RA in the hands, you'll see it in the forefoot in the altered position of the toes as well. And anytime there's immobilization, trauma or immobilization, that predisposes them to osteoarthritis. And then gout comes from, it commonly affects the MTP joint of the great toe. So they get pain in their great toe, MTP joint, and that's gout. I would put a star by that. Gout affects what?
Great toe.
MTP of what?
The
Great toe. So with any osteoarthritis, what do we commonly see? Hypermobility or hypomobility? Hypomobility. Do we commonly see capsular pattern of restriction or non-capsular? Capsular, because now we're affecting the joint surfaces. We do think, I think you've done balance strategies with RX. So think to your balance strategies, you do use your ankle strategy first. So that strategy is affected with anyone with an ankle pathology. So they are compensating higher up in the chain for balance reactions, but they just straight up have poor balance from the get-go. They cannot balance. And then if they have osteoarthritis, weight bearing is painful. So what do you see with an antalgic gait? You tell me, what does it look like?
Shortened stance time on the affected leg.
Yep, and then what on the unaffected? Shorter step length, because they're trying to get off the painful side as well. And then if they have pain with that ankle, then you're really also going to see that ineffective push off as well, because they're not able to use their ankle. So they probably are using an assisted device. What about sit to stand? What about up and down stairs? What kind of motion do you need at your ankle? You need a good amount of dorsiflexion to get down in that position or to push up from. So you need a lot of dorsiflexion range. What about strength? To get yourself up the stairs.
You need at least a 3 to hold it against gravity while you're bringing your foot up to the next step.
Yes. What about plantar flexion strength to push you up a step? Yes, we need it. Yeah, you need a good amount of strength. So these you're going to see functional difficulties with ankle OA. If it progresses and becomes so severe, there is a total ankle. We're not going to go through it. It's not very commonly seen. Maybe you'll see it in the clinic. It's quite rare. But they also might just use the ankle. So they might do that as well. We're not going over total ankle, but it is out there. It's like a busy room over there right now. So as with any osteoarthritis, they need to have that pattern of rest versus activity. Can't overdo the activity, but they gotta use it or lose it. With RA, same thing. You know, they have to have some activity to maintain activity, but they can't overdo it. And then we're often might be looking at shoe inserts, orthotic shoe inserts, to realign forces and correct any abnormal forces within the foot. And then you really want to do passive range, active range, passive to active range as tolerated. Aquatic therapy is great with anyone with a lower extremity osteoarthritis. And you start with what type of strengthening with your arthritis folks who come into you? What type of strengthening would you start with?
Closer. Or isometric?
Isometric. Yes. And then you can progress concentric, eccentric, open chambers, closed chamber. So we've kind of gone through all of this. So one of the goals is increase mobility of soft tissue and the muscles. So if you were to do stretching, what muscles would you stretch with this patient? Gastro? Yes, you stretch the plantar flexors. They tend to be tight. And so offering that increase in flexibility, then they can increase their range of motion to do all those functional activities. What else? In terms of balance, what would you do with an arthritis person to increase their balance reactions at the ankle? What would you start with? Give me a starting exercise.
Just I would do either bilateral or single leg stance with upper extremity support.
Yeah. Either bilateral, start bilateral, see how it is. Maybe it's too easy, then you can go single leg stance. And how would you progress that?
Hands off.
Would you just go from here to here with like an 80-year-old?
No, you.
Probably do fingertips, one finger, and then hands off. Now what do? You can have close your eyes. Ugh, just kidding.
You could also put them on an uneven surface.
Like you could put them on foam, a pillow, foam. What else could you do after foam? Just kidding. It's probably closer to your end point. Trampoline, just standing on the trampoline, it's more unstable than foam. Then you can work up to standing balance on the bump suit. Yeah? You could do tilt boards for anterior, posterior, lateral, but I would go through all of that. Every time you make it harder, what do you give them back? So they've been doing this totally fine, groovy, and you're like, all right, I'm gonna put a piece of foam under you. What do you give them back?
Something to balance.
Give them back their hands to start, and then work off the hands each time. Even if it's within that same session, you get them back off the hands, but you gotta give them back something to hold on to. So always do stuff like that close to parallel bars. Okay, any other questions with osteoarthritis? Your arthritis folks, should they keep running?
No.
No.
Should they play some basketball? Pickleball. They should probably be avoiding high impact aerobic stuff. Cycling, good. Swimming, good. Low impact items or low impact activities are good. Okay? All right, so you know all that. We're good. Let's keep it grooving. So let's go through the different fractures that can occur at the ankle because there's a lot of different fractures and precautions that go with each. So first are malleolar fractures. So you can fracture the lateral malleolus, medial malleolus, both, or both plus the posterior portion of the tibia. So you can get all kinds of crazy here with the malleolar fractures. If it's pretty simple and maybe they just fracture one, they probably would just ORIF. If it's pretty comminuted, so multiple pieces or multiple malleoli fractured, then they'll probably go in and do an ORIF. So they'll put a plate to stabilize on the side with screws going in. And then post-operatively, they're gonna be in a splint, or not a full-blown cast, but an ankle splint. Usually we can take it off to do dorsiflexion, plantar flexion. But you don't wanna do inversion or eversion with a malleolar fracture. Why? Because why?
It will just refracture.
Yeah, well, your inverters and everters hook around the malleolus. So we don't want to stress them because all that's still healing. If they get full dorsiflexion, plantar flexion, oftentimes they can progress to a walking boot with walking. We have also seen that these patients who get the screws and plates may, a year later, go in for a surgery to remove the screws and plates. This is one of the only places that I've seen in the ankle is where they actually will go back in and remove the hardware after everything's healed up. If it's like a young person with good bone stock, they may actually do a revision and just remove all the hardware. So be aware of that. So they're in a cast. Can you mobilize the ankle if it's in a cast? No, it's in a cast. So you can't do anything with the ankle. You can have them move their toes so you avoid swelling, prop it up. What else can you do with this patient who's in an ankle cast?
Do stuff the knee.
Asymmetric.
Above, yes,
Oh,
move the
above.
toes, because that's all that's below.
The knee.
Knee strengthening, hip strengthening, other leg strengthening. They're using an assistive device, you gotta work the
Upper extremities.
Upper extremities, yes. After they remove the cast, what are we gonna work on?
Range of
First.
motion.
What type of range?
Passive.
Usually passive outside of a cast, to active assisted to active. Then what do you start? Or at the same time? Start those isometric, get those muscles firing again. So isometric at the ankle. Dorsiflexion, plantar flexion. You can do inversion, eversion. Have them put their hand on either side of their foot. Then you can progress to adding resistance. We're going to talk about progression in just a little bit with different things, so let's just keep going. So the next fracture is a pylon fracture, and this is actually a distal tibial compression fracture. And what happens is there's an axial load that compresses the tibia down into the talus. So you could think about a land from a jump down, and so you have that axial compression that drives the tibia down into the talus. So it's a compression fracture. Usually, I mean, that's beautiful. Usually it's an ORIF. These patients may be your external fixator patient to stabilize all that. But the most common issue with external fixators would be malunion. It could be the most common complication. If they have this, usually they're non-weight bearing for about 12 weeks. Because it's an axial compression injury. So anytime you put that leg in weight bearing, you're going to increase that vertical compression through the leg. So you should also, you have your special tests list, right? And you have a precautions list. If not, you should by now. So precautions with pylon fractures should say avoid weight bearing for 12 weeks because it increases vertical compression. That's your why. So post-operatively, you're going to do everything we just talked about. You can strengthen the other leg, aerobic fitness, upper extremities, any of your range of motion and strengthening, you can do non-weight bearing. Because they're non-weight bearing for 12 weeks, but you can do it in open chain. So you can do, like she's sitting open chain, you can start in that position. You can actually start, when you do start strengthening them in this open chain position, by adding TheraBand. That's strengthening in the open chain position. That way you're not loading through the tibia. Then as you get to partial weight bearing, you can work towards the stationary bike. And then once we're clear for weight bearing, then you can start doing like total gym where you don't have a lot of vertical compression and increase from there. Make sense? Okay, so we're going to keep talking about other stuff. So we've got malleolar fractures, we've got a pylon fracture, and then there's calcaneal fractures. Again, this is usually from a fall, and you can have a fracture through the calcaneus or a calcaneus avulsion fracture, which is usually caused by what? Achilles tendon, so a rapid contraction of plantar flexion just pulls that piece of the calcaneus off with the Achilles tendon. So it's usually pretty conservatively treated, any of the calcaneal fractures, but non-weight bearing, because what do you heel strike on every time you step? You heel strike with your calcaneus. So generally rehab follows the same thing. You're going to start with isometrics. You can do manual resistance or open chain resistance for dorsiflexion, plantar flexion. And then when you get to soleus strengthening, this is a really good soleus strengthening exercise. So you have them prone with their knee flexed to 90. Why? Why would I flex their knee to strengthen their soleus? Say it loud and proud because I'm hearing the jump.
It takes out the gas.
It takes out the gastroc because I have actively shortened the gastroc. It's not playing a role in this motion at all anymore. So it's all soleus if the knee's flexed, and then you can take an ankle weight and wrap it around their foot and have them strengthen like that. Pretty cool. Mitch didn't know this? I'm just kidding. That's pretty cool. So that's soleus strengthening. Really cool exercise for that. But you really have to focus on gait training with a calcaneus fracture for heel strike. They oftentimes will get in a pattern of like mid-foot strike, like a runner, because they don't want to strike the painful calcaneus, but after it's healed, you want to work on heel, strike. Yeah?
Yeah.
Okay. All right, so what fractures do we have so far?
Calcaneal.
Calcaneal,
Malleolar.
malleolar, pylon, and now we have a talus fracture. So this is also a fracture from falling from a height and landing on your foot, but oftentimes you're in a crouched position, so you're trying to catch yourself down, and you end up fracturing the talus. The pylon is more that you have a straight leg when you land, and so you fracture through the tibia. So this is like this axial load through the talus and calcaneus. Obviously, it leads to OA, subtalar OA. And they usually will have either a cast or ORAF that talus. So this would be like someone in an ankle cast where they're in dorsiflexion. It would be for the talus. They can go in ORAF if they need to, if they're quite displaced. They need to bring the pieces together. Pretty common either way. So post-operatively, usually if they have an ORIF, you can take it off for exercise. They've stabilized the pieces. But again, with all of our ankle issues, they tend to be longer, non-weight bearing than other lower extremity issues. So we tend to see 3 months of non-weight bearing because the ankle is taking all the impact every time you take a step. So it is longer. So if they are non-weight bearing, what can you still do with them? What would you do above them? Well, there's not much below of an ankle.
That's
Still toes, but yes. What would you do?
Open chain exercises, if they're not okay, so like hamstring curls or like hip four-way, just not putting weight on them.
Yeah, you could totally have them in sideline doing some hip stuff for hip strengthening. You could do knee open chain exercises. You can add resistance as long as it's above the ankle. Don't put an ankle weight at the ankle because that's going to stress it, but you can resist the hip and the knee above the ankle. Next step is a stress fracture. This is probably one that you've heard pretty commonly. Someone who has a stress fracture. Pretty common in the lateral malleolus. Os calcis is part of your calcaneus. The navicular or sesamoid bones. But usually they're like, oh, I've got a stress fracture in my foot. And a stress fracture is commonly from what type of activity?
Strenuous.
Too strenuous of activity. They are doing too much activity, they're not resting enough, and they don't have enough muscular strength to meet the activity demands. So they'll usually get a stress fracture. So someone who has a stress fracture, it's usually non-operative. So they come and see us, and so what's our first piece of advice?
Let's just stop what they're doing. That's
Rest
everything.
and stop doing that. Stop playing basketball, stop doing whatever you're doing, get off the feet, we need to rest for right now. And then you're going to start all of your training to really strengthen that, everything back up. Start with isometrics, work on your range. Most often you'll have tight plantar flexors, so you want to stretch that out, and then work isometric concentrations. Yeah? We know the pathway. Any of the closed chain stuff, wait until we have evidence that it's healed, or we're outside of that 6 to 8 weeks. And then your end phase would be progressing to plyometric type activities. Don't do that too soon. Okay, so that's all of our OA and fractures. We made it. Are we still plugging away? Yes, we are. So you've done ankle sprains in Varex extensively.
No.
You're not confident. You're not confident anymore. Okay, so what type of ankle sprains are there?
There's three
First, second,
types.
and third.
Yeah.
Good combination.
Oh, you're correct.
There's a lateral ankle sprain or a medial ankle sprain, right? So what ligaments sit on the lateral aspect of the ankle that are torn or sprained with a lateral ankle sprain? This was is a test question on
Interior
Knies.
of the
Do you remember?
Always torn first?
Always torn first. Anterior, talofibular, and so anterior talofibular is over here, right? You got your fibula. This is my drawing skills. You got your calcaneus, right? Oh, that's your talus within there. So you got anterior talofibular going to the talus, to that calcaneus. What's next? In the lateral. You gotta label this in Knies. What's this one? Calcaneofibular. And then what do you have back here? Posterior talofibular ligament. So make sure you review your ankle ligaments. So those are your lateral ligaments that are torn in a lateral ankle sprain. So what is a first degree lateral ankle sprain? It's the always torn first. So you have a single ligament rupture of the ATF, yeah? So what's a second degree? Next one. Yeah, you've progressed now to calcaneofibular, fibular, calcaneal. Depends on whoever you're reading it from. What's a third degree? All of the above. Okay? So you've been here before. So what are the tests that would test for lateral ankle stability of the ankle? Because there's an anterior drawer test of the knee.
And the shoulder. And the shoulder.
And the shoulder.
Is there one for the
Scour test.
Yeah.
That one always sounds awful. I hope I never have to do that to anybody. Just quick.
Does it hurt yet?
Talar tilt. You want to test the integrity of the talar motion because all of these, well, not all of them, these two go to the talus. So if they're torn, you're going to have excessive talar motion, excessive talar mobility. So anterior drawer test and talar tilt. So by Thursday, you're turning in your anatomy and your special test of the ankle. Got it? Good. Okay, so what are the ligaments on the medial aspect? I don't have to draw it. It's the deltoid. The deltoid ligaments. So those are torn in a medial ankle sprain. Which is more common? Oh, my pictures.
inversion?
The lateral?
The lateral.
The lateral ankle sprain is way more common than a medial ankle sprain. Usually if they've sprained their medial or their deltoid ligaments, they more than likely have a medial malleolar fracture. So they'll repair that or cast it for the fracture. So you're usually following the fracture one with that. So non-weight bearing, cast it, all of the above. What about a high ankle sprain? Oh shoot, I fixed this and I forgot to upload it. Sorry. You gotta fix it. You find the error on the slide and tell me what it is. Because I totally fixed it. So are you seeing ligament?
Tibio.
There it is. What is the ligament?
It's not that.
Not that.
Tibio.
Tibiofibular ligaments. I fixed it and then, I don't know. I got a mommy and I got pulled away and so never got uploaded. So fix it on your PowerPoint right now. That a high ankle sprain involves anterior and posterior tibiofibular ligaments, interosseous membrane, and all of the above. Yeah? Okay, we fixed it. We're good. So special tests for a high ankle sprain are an external rotation test or a squeeze test. And then obviously x-rays and MRIs can diagnose that as well. Because it's so high, they will immobilize this quite significantly, limited weight bearing, maybe even surgery. Who commonly gets a high ankle sprain? And why? Which athlete?
Anyone that has like.
Soccer players.
Soccer players. Who wears high tops?
Oh, man.
Basketball players. Because they tape their ankles into dorsiflexion, and then they wear their high tops to avoid sprains. So if they sprain, they are spraining above the high tops, and they all tape their ankles. Football players, basketball players, they all tape their ankles before they play. So if they're spraining, it's quite significant. Yeah? Okay, so ankle sprains. We've been here before, so you're telling me. You ready? These are the common impairments that you guys know about. Sure. What is within a ligamentous structure that you have to work on through your rehab? What information do ligaments send to your brain? Yes, so you have to have proprioception at some point in ankle sprain rehab. Yeah? So first up, you got an ankle sprain, any kind of ankle sprain. What are you doing? Rice. It could be an air cast. It could be, we're going to do these next week on our orthosis day, a semi-rigid brace. Do they tend to weight bear, partial weight bear, non-weight bear?
Partial weight bearing.
Get some weight bearing off of that ankle, let it heal. So they're non-weight bearing or partial weight bearing. They're in some kind of splint or orthoses or price. But what are you going to do in therapy? Which directions are you going to start range of motion? If it's a lateral ankle sprain, most common. Dorsiflexion and eversion. Why would you not do plantar flexion and inversion range of motion?
Because that's probably more than likely what was injured.
Because those ligaments that resist that motion are torn. They have excessive mobility in those directions. You don't need to range it. And you're just tearing those fibers further and further apart the more you go into those directions. So dorsiflexion and eversion. So you have your precaution list, right, for all your diagnoses. Lateral ankle sprains, no plantar flexion and inversion. Yeah? At least in the max phase. So strengthening wise, where can you start isometrics? You can do isometrics. You should be activating everything, but really focus on dorsiflexion and eversion. Strengthen all that up to support the ankle. And then you can do what to the rest of the leg? Above and above. Not much below. And the toes. I mean, don't forget about them, they'll get swollen. Have them move their toes. They can get a towel and scrunch the towel with their toes if you need to do some toe strengthening. But we'll talk about some more foot strengthening as we keep going. So in the mod phase, as we're progressing through healing, the other thing I want you to start doing and understanding is we're talking about the phases. Associate that with what stage of tissue healing this tissue is in. Because that might be a very big question on the capstone. What stage of tissue healing is that tissue in? Therefore, what phase of rehab are they in? So coming back to that initial stuff that we talked about, tissue healing for all the tissues, what stage are we in when we're in the mod phase? Yeah? Okay. So now we can start weight bearing, progressing off the assistive device. Keep using braces. You can add tape for stability, but still you want to keep avoiding that plantar flexion and inversion with a lateral ankle sprain. Yeah? You can start strengthening in that non-weight bearing position. So you can start adding TheraBand in the long sitting position for your strengthening. You can do those toe curls. Be careful with the writing of the alphabet because you tend to do that with cursive letters, which brings you into plantar flexion and inversion. If you're even just an A in the alphabet with your foot, you have to go into plantar flexion and inversion to get that full circle for the A. So be careful with that one. But you can do ankle weights, TheraBand in the non-weight bearing position. If you are progressing from non-weight bearing or open chain to closed chain with any of your ankle stuff, do you just, hey, let's have at it? Or what's a good middle ground from non-weight bearing to a weight bearing activity? What's a good transitional point?
The what?
Like 50% weight bearing, so like if they're just standing
If they're
half
up
on
on
the
the
bench.
You can actually have them sit. So they can put weight down through their feet, less than 50%, but it starts all of your closed chain stuff in sitting and then do it in standing. So we tend to do a lot of sitting stuff with the ankle before we progress to standing. So you can actually have them do sitting heel and toe raises and then progress to standing heel and toe raises. But you have to watch with toe raises. What do you have to watch for?
Pushing up, pushing
Yeah,
up.
pushing up.
Let me do that again, over here, where everybody can see. What do you have to watch for with the toe raise?
Oh.
Pushing
We
their
have
butt.
ankle sprains for gait, and then they had a brain injury.
But what am I doing?
Just leaning forward.
With my trunk? I'm not using my toes. That's like no dorsiflexor activity with that motion at all. So you have to watch that. We want to, you gotta use a mirror, you gotta use that feedback here to get them to use their toes. You can do all of your plantar flexor. This is all plantar flexor stretching. Non-weight bearing, use like a gait belt or any kind of stretch strap. Not TheraBand, stretch. That's not gonna work. Gastroc soleus, you know the difference between stretching gastroc and soleus. You definitely do, because I didn't do that. Me. You can also do over the edge of a stair or the curb for really deep heel cord stretching. Okay? And they can be doing the bike. Are we good with mod phase? Hopefully this just adds to your plethora of information. And then the min phase, you're really progressing resistance-wise. If they're athletes, we're really progressing into return to sport. So, in this phase, what type of resistance training would you be progressing to? Final phase.
More
Definitely weight bearing.
functional, advanced.
Close chain.
Closed chain. Isometric, concentric, or eccentric? Eccentric,
Yes.
for sure. So what is eccentric for plantar flexors?
Going up and then eccentrically controlling the way down, maybe on a single foot.
Or you can start double. Let's
Yeah,
not be too
double.
crazy.
Okay.
Let's not be. You can have a flat ground. They go up on a heel raise and they have to slowly lower down. Oh, you can't see me. I mean, we can't
Go
see
up
you.
and down.
You go up, but I mean, you can have hold on, right? So you have to hold on. Up with 2 feet, slowly lower down. How can I make that harder?
Well,
your
one foot.
Close your
Before
eyes.
that, let's.
Up with 2 feet and then raise one leg and slowly go down with one.
Before that.
Before.
Close your eyes.
What kind of thing could I put this patient on that would increase the amount
Uneven
of
surface?
a step?
Oh,
You
a
can
step.
have them with their feet, their heels over the edge, so they go up,
Oh, they go.
and then they have to go deeper down,
Got you.
over the edge, like the heel cord stretch. Bilateral. Then you can switch to unilateral, up, slowly lower down. And then you can add a ballistic where they go up bilaterally, slowly lower unilaterally. Yeah?
Okay.
You see that progression?
Yes.
And how it's deeper over the edge of a step? Because that's important. Strengthening when we get to tendonitis for Achilles. So table that. We good? Any of your proprioception stuff that we've already talked about. Balancing, you can do forward, backward walking. Usually you'll have a piece of tape on the floor. This is your DWI step, right? On the tape on the floor. So that's a lot of ankle stability, right? You can do crossover sidestepping. That's the grapevine. You need a lot of ankle motion to do the grapevine. That stuff. And then all of your agility, like ladder drills and stuff like that. Yeah? Okay. Is any of that new? Does that help you overall?
Yes.
Okay. It's not totally old info. If they've had an ankle ligament sprain and then they just have chronic laxity of the ankle ligaments, they may need surgery to stabilize it. And usually what will happen is the peroneus brevis will be rerouted to kind of stabilize that distal fibula. kind of reroute the muscles. So then post-op rehab is pretty variable depending on the surgery. That will be immobilized, and then you kind of go back through your dorsiflexion, plantar flexion, open chain, and progress through all of your same progression that we've already talked about. They have usually chronic lateral instability, so avoid plantar flexion and inversion. Yeah? And then these folks, you'll want to do a lot of proprioception because they've had chronic issues around their ankles. We're on track. My goal is to get through the Achilles today. We are doing it. Let's go. Okay, so Achilles tendinopathy. We've got that nice Achilles tendon. And a tendinopathy, tell me about it. What is a tendinopathy?
Isn't it like,
Overuse injury.
it's
Do we
like,
have inflammation present within tendinopathy?
I
I think so.
Yes.
Usually that's a tendinitis, and it could progress to a tendinopathy, so it's more of a chronic issue. If they have Achilles tendinitis, you're in that inflammatory phase with that Achilles.
So then is it tendinosis, instead of more chronic tendinopathy?
Yes,
Because tendinopathy doesn't usually inflammation.
yes, yes. So if you're in the itis phase, you gotta work on dealing with that inflammation and then progress from there. If you're in osis or apathy, you're out of the inflammatory phase, but we're in a chronic overuse condition. Okay, you absolutely have to put a star, like you will be asked to tell me information regarding factors that lead to Achilles tendinopathy, intrinsic and extrinsic. You can guarantee that you have to know this information. Why do people get tendinitis, tendinopathies of the Achilles? Usually they have a decreased vascularity of that Achilles tendon. There's a malalignment of the rear foot to the forefoot. They usually have tight gastrocsoleus complex. And then they have variations in training. So they're not cross-training. So they're only singular sport training, sport-specific training rather than cross-training. Maybe there's a change in running surface. You've got someone who typically runs outside, but winter hits, so now they're running on a treadmill, or vice versa. Treadmill runner that tries to run outside. Or poor footwear or new footwear. So they've got, chronic shoes, not chronic shoes, old shoes, and they buy a new pair of shoes, chronic shoes. And they buy a new pair of chronic shoes. And then they have to adjust to the new shoes. Or they've got shoes that are like talking to them, they're so old and torn apart, and they need new shoes. And sometimes it's literally as simple as buy a new pair of shoes.
We were talking about you, John.
That'll be $100.
yeah.
Of your
You're
shoes.
gonna keep that.
So John, because you were not here, you have to know these factors that lead to Achilles tendinopathy.
Okay.
Guaranteed. So signs and symptoms of Achilles tendinopathy are what?
Pain.
It hurts where?
Right here.
Right
No,
here.
it's
Right
only like
there.
the specific
It hurts
spot.
right here at the Achilles. It's usually swollen. And you'll have crepitus at the ankle. Maybe that's my problem. My ankle pops every time I take a step. I've got a lot of problems with myself.
I have crepitus in like everything from the down up.
So, management is usually pretty conservative with our tendinopathy. They've overstressed it. Usually they're doing just rehab. They may immobilize it for like up to 2 weeks if they're especially very inflammatory, and then do rehab, but we're doing conservative treatment. And we're doing this. Okay, so what can you do for this patient who has a tendinopathy, or a tendinitis? What can you do physical agents wise for this patient? Ice, why? That's gonna be my question, why?
Tendinitis,
Swollen.
Why would you ice this?
to decrease the inflammation.
And the pain.
So-
Okay, what else can you do?
Ultrasound, the tendon or ligament injury.
Yes, you could, tendon, you can do ultrasound. What else can you do? Have you guys done phonophoresis? Or maybe just briefly talk about it?
We talked about it.
You can do phonophoresis as well.
They told us it existed.
It exists. That's, yeah, you can, occasionally, literally I wrote occasionally. They'll be on NSAIDs, they should do what? It's an overuse condition, so rest, stop, avoid running, avoid basketball. They can switch to non-impact sports I'm going to make sure we get through this, so I'm pushing us. The other big thing that I absolutely want you to know that you can do for Achilles tendinopathy is you can put a heel lift in the shoe. And by doing that, it reduces the stress on the Achilles tendon because it puts them in a little bit of plantar flexion, and that will allow that Achilles tendon to heal. So you can do what? Pretend. You can put a heel lift. And these heel lifts are, you can put, Jules, do you see me? Heel lift for Achilles tendinopathy. Okay. And these are really good heel lifts because they come in, it's like layered. So you can start them with the full layers, and as they progress, you can peel off a layer and make this heel lift a little bit smaller, and peel off another layer and make it really small. So you get rid of the Coolio off the shelf heel lift. So we talked about what are the problems they have. They usually have tight plantar flexors, so you need to do what? Stretch them and work on dorsiflexion range of motion. And then you can progress strengthening, but we're still in initial phases, so do you want to be aggressive? Submax. The other thing that you should know by now, with any tendinopathy, anywhere, you should be incorporating eccentric training. It's an overuse condition, and they do not have the muscular strength to support the amount of demand they're putting through their body. And what is the true strengthening type of resistance? Eccentric. If you want strength gains, you do eccentric training, and you increase that time under tension. So this is where you pull out the heel raise slowly lower. Yeah? Because that eccentric, it's a heel raise on 1 second, and you slowly lower over 3. So you have 3 times as much time under tension than you did for your concentric up. Does that make sense? Yeah. Okay. So things we're doing with our Achilles patient, we're doing what? Heel lift and eccentric strengthening. Okay. But what happens if either they don't see us? Oh, I was gonna pull up a video of a basketball player rupturing his Achilles. Google it, YouTube it. Achilles tendon ruptures.
Aaron Rodgers.
Aaron Rodgers.
I think it was, gosh, at this point, like 7 years ago in the NBA Finals. I think it was the Oklahoma.
It always looks to me like
Oh,
those
was it?
windows curtains where you look and they go.
Yes. Look that up.
Yeah,
It's
I get
gnarly.
it.
And I was literally watching it with my husband, and I was like, he just tore his Achilles, and it was like game 2 of the finals. And they were like, we're just waiting to hear back from the locker room. And I was like, he tore his Achilles.
She runs onto the field. I know.
And sure enough, they come back and they're like, he tore his Achilles, he's out for the rest of the finals.
If
So-
you look up the Aaron Rodgers one, it has a really good camera view
Oh,
of his calf.
crazy.
And it just,
You can see it retract.
Right.
Okay, so everybody, that's your homework, is you're gonna go YouTube some Achilles tendon ruptures, because it's gnarly. So, what happens if it gets ruptured? What happens to the muscle? Same with the biceps tendon rupture. It usually shortens and retracts up. So, the odds of that healing is quite rare. They usually need intervention. So, signs and symptoms are what? A ball of mass up in their proximal leg. It's painful.
They can't plantar flex.
Can't plantar flex because there went their plantar flexors. And what's the special test for an Achilles tendon rupture? You guys already said it.
The Thompson.
The Thompson test. Yes? Okay. Special test. So treatment, they can be non-operative. They can cast it if they feel like we're in close proximity. But like an older person who we're not expecting a high level, I say older, but look at the age for that. Okay, so we're not expecting a high level of demand for this patient. They could be casted. Or cute, younger, elite athlete, they're going to surgically repair that. They're gonna bring those pieces together and surgically repair it. The only problem with that is the area that the surgery is in. You tend to have a lot of wound closure problems with that as well, and nerve injuries. So, yeah. So non-operatively, if they're immobilized, are we going to do anything with that ankle?
No.
No, if they're immobilized, you can't. So you're gonna do what? Above and the toes.
And the toes.
Strengthening. You can do the bike with the other leg. Not, obviously not a moving bike, a stationary bike, because they're not gonna go anywhere with one leg. You can do the arm bike, upper extremity strengthening. What about when we take that cast off? What are we gonna do?
Range of motion.
Yes, it's going to be very hard for them to get that range back. Very long process. It is very slow, and so you can use your modalities that help before, like so heat before, you do range of motion to progress that. Be gentle though, like as much as we want it to come back, you don't want to suddenly plantarflex dorsiflex them because you could just tear that sucker right back out. But you can give them what in their shoe to reduce the demand on that Achilles heel surge. You can give them a heel lift. Yes, you can put that sucker in their shoe as they're healing. So non-operatively, this is my picture I was looking for. When you start strengthening, you start open chain, but when you progress it to closed chain, what position do you start in?
Seated.
Seated, so you can have them do heel raises, toe raises, seated. You can even have them do the, BAPS board, seated for range of motion. Everything you can do seated before you put them into standing. So then you can weight bear. If you want to do squatting for dorsiflexion range of motion, what would you start them on?
The total gym.
Start on that total gym. So you reduce the demands of the weight bearing. And then eventually you can work up to heel raises just on a flat surface. End game would be over the edge of a step. Gotta do proprioception exercises because it is what type of tissue? It's a ligament. So you gotta do proprioception, but you can begin all of that proprioception in seated to reduce the demands on this ruptured tendon. Yes? Okay, we are doing it. We're going full force. We're gonna get through this Achilles. So if, though, it's torn and they aren't casting it, they're gonna repair it, surgical repair. So there's two options. They can do an open, minimally invasive, they just put the ends together and sew them together, repair, or they have a delayed repair, where they actually use an autograft from flexor hallucis longus, plantaris, or peroneus brevis, to, just like with the ACL, to merge the pieces together. So they might use a graft, just depends. What are the complications following a surgery? DVT. You have
The loss
Yeah.
not as common in this one. Think back to that ACL. Why do you have those precautions after ACL, PCL?
Because it's a weight bearing.
You don't want to re-rupture that just surgically repaired tendon. Think back. I specifically put this in your ligament stuff in the knee, that graft undergoes a series of changes.
Mm-hmm.
Yeah? From the knee stuff. Same thing if they have a graft at the ankle. So it is going to get weaker and then become stronger. So make sure you know that in these complications. Post-operatively, they're usually immobilized for 6 weeks, and usually non-weight bearing. If it's delayed, then they'll be non-weight bearing for even longer, okay? So there is also an accelerated rehab approach. Depends on the research of the surgeon, and newer versus older surgeons, but there's an accelerated approach where they weight bear sooner. It's like a primary repair, they kind of get back to it sooner, and they haven't shown deficits with that. So there is an accelerated weight bearing approach to Achilles repairs. So it kind of depends. It all depends. It depends on the surgeon and just what you're going to follow and the weight bearing status and all that. So if it seems sooner than normal, you probably have this kind of a surgeon who's in the accelerated books. Yes? Rehab is generally similar, so you've got your exercises I gave you here, copy them. It's just sooner with the accelerated approach. Make sure you go through your exercises and you know when you're doing what in terms of phases. Max, mod, min. Precautions, in terms of an Achilles tendon repair, you have to avoid stretching the gastrocnemius. Avoid stressing that tendon. So you're also going to postpone any unilateral stuff till quite far out. You shouldn't have any pain. You should do everything bilateral first before you do anything unilateral. Yeah? So make sure you know your precautions with every single lower extremity thing we've gone through, but especially the ankle. So what do you have to know that you're turning in for me on Thursday? Special tests, and you already have them for hip and knee. So you have to know your special tests, but your precautions that go with every single injury or surgery. Do not blow surgeries because you don't know the precautions. Yeah?
Yep.
Okay, so everything else is pretty much the same. But in terms of reflex inhibition, it's more likely dorsiflex or plantar flexors in this case. Yeah? So it just depends on the surgeon, weight bearing status, how aggressive you can be, and we kind of tend to follow that. When you start increasing range of motion, you can do self-stretching. You can do a seated towel stretch, like a towel or a stretch strap for plantar flexion stretching. You can do a slightly flexed knee versus an extended knee because you're doing gastroc versus soleus. What else? You can do range of motion on the backs board. You could have them do towel scrunches for their toes, picking up a marble and moving it because that's range of motion. And then you can do open chain for the hip and knee, closed chain into that heel raise and down. What would you start that in? If you're starting heel raises, seated. Start as seated. And then by the min phase, you can do what type of training for those plantar flexors? Eccentrics. You can have them go up and slowly lower. Usually, like, we're talking 16 weeks before we're starting plyometrics and really pushing them. But yes, questions? We did it! We should. Woo! I'm so proud of us. Thank you for hanging in there. So all we have for Thursday is compartment syndrome, shin splints, and plantar fasciitis. And then we're going to review. So Thursday, anatomy and special tests. Turn it in. That's your discussion for today. Don't forget your surgery assignment. Think of it as 3 points. Just follow it and do what it says and be thorough and write a paragraph for each response. And you should be able to get full credit to pad your assignment score.
So that's formatting.
Follow the formatting, follow what it says.
Follow.
Yes. Just do what it says. Literally, I gave you links that say